Okay, so again, I wanted to thank everyone for joining us. I see that there's 11 people with us so far, and that's great news. Love to see that. Today's webinar is presented by DDME and Whipmix, and I'll let you know that those two companies have put together a program that we believe is going to be very helpful to dentists who either want to do a great job of protecting their patients' teeth and restorations and protect their airway and provide some of the health benefits of dentists managing patients' airway issues. We've developed a very thoughtful and comprehensive program, and one of the concepts that we are offering is the ability to bill medical insurance. So there's some amount of effort involved with that task, and some of you may have already successfully billed medical insurance and are in a good position to help out and provide any input, and some may just be getting into this. So what we want to do is cover the basics, and for today's meeting, the topics for today is going to be obstructive sleep apnea and dentistry, billing medical insurance, and we're going to cover the business considerations in strategic development. And by that I mean, if you understand what the implications on the decision to bill medical insurance are, then you can develop a strategy to achieve that goal or decide not to. But it's always better to have informed decisions ahead of time and then develop a strategy. We're also going to talk about Medicare. Medicare is a payer, and they have unique requirements. So, and Medicare is obviously very influential on the medical payer side of things. So we are going to spend some time talking about that and compare Medicare versus private insurers. So there's a number of different types of strategies and requirements, I should say, if you're going to see a Medicare patient, a private payer, and then based on the payer and then based on the geographic region. So we'll talk about some of those subtle differences. And I'm going to take you through a step-by-step, in general terms, what payers generally require. And I don't mean to be excessively vague. However, the requirements do vary from payer to payer and from region to region. So the idea that at the end of this you could exactly use this for billing medical insurance, it's conceivable, but there's very likely some special requirement that payers in your area or the type of payer that your patients are, you might have to add or subtract, excuse me, subtract a step to do this successfully. We're going to talk about the BRX Pro and also the monitor that we've used and have a lot of experience using both in the medical and dental field, and have been very successful at using this monitor for billing medical insurance. So we'll talk about the technical requirements that payers have in order to accept a diagnosis. Okay. So I'm going to just check here for questions in my chat box from time to time. Okay, so what we're going to talk about on this slide is there's a list of business considerations to make and then a business decision to make. So I wanted to kind of provide an overview of the concepts and requirements and try to characterize fairly the amount of work to be able to bill medical insurance. That way you can decide that's what makes sense for your practice or not. And then if you do decide to proceed, what's the path to achieve that? Because it is a little more work than most people make it out to be. So on the positive side, there's, when you bill medical insurance, obviously you're using an existing benefit for your medical benefit for your patient. So from the patient's perspective, that's a huge advantage, although that advantage is shrinking due to the skyrocketing costs, a level of deductibles, and also the skyrocketing costs of getting that medical benefit. So the idea that you can use that benefit is still extremely attractive to patients, but oftentimes, unless they've used up these growing deductibles, it's still going to be an out-of-pocket. It's just going to go towards our deductible. So eventually down the year, maybe, or if you do your test later in the year, they'll have satisfied their deductible requirement. and then it will tap their medical benefit. But just know that I believe the average deductible now for a typical private policy is like $1,500, and that's the average. So we all know that there's kind of catastrophic types of payers or policies, and then there's very expensive policies that have a much smaller deductible. But at the end of the day, we have to we do want to use the patient's medical benefit. Another pro that, in my view, is that when, as a dentist, and you're helping patients with their airway issue, whether it be obstructive sleep apnea, bruxism, snoring, upper airway resistance, or whatever the case might be, as a dentist, if you're going to bill medical insurance, you do have to follow a certain path, and that path is essentially a medical path, and we're going to review that. And there's some tremendous upside to that medical path from a clinical perspective. It's potentially lucrative. When the word gets out, you can use your medical benefit to use oral appliance therapy for the treatment of sleep apnea or protect the teeth against the damage of bruxism. That becomes a very attractive marketing tool for you. So it could potentially grow your practice and add not only the satisfaction of helping your patients with this problem, but it could also add tremendously to your practice's bottom line. And then it also, if you're going to be successful at treating patients in this area, it does require a team, and you will need to interface with your community. That is with physicians, sleep labs, and so on and so forth. So in the course of being successful at satisfying the integration of this service to your patients, you will be integrated into the community, and that does present a number of options. So those are all upsides. Some of the challenges that we face are you do need to get a DME license. Okay, so there's some grief. When I say grief, there's some effort and cost associated with that. So the Medicare outfit has a process that you need to go through, and it's a 25 to 30 page application, and I believe there's a $400 or $600 fee to submit that application. And then once you've finished that application, which is not a simple thing to do, then the application will be reviewed. And then once it's reviewed and there's no objections or questions or inputs back from Medicare, they will then schedule a visit. And they'll just want to go through and look at what you're doing, make sure that you're doing what you say you are doing in the application. It's a relatively minor inspection, but there is a physical inspection involved. Okay, and once that's done, then you'll be granted your Medicare number. Now, one of the things that I'd like to mention about that is you may not actually ever treat Medicare patients, but there is still a compelling reason to get your Medicare number, and that would be that if you want to get in network with some of the private payers, the very first question on the application is, what's your Medicare number? Okay. All right, so the next thing is on the challenge. It's billing medical insurance is completely different than dental insurance. It's probably not any easier or harder, but it's just different. So there's some skills applicable from billing dental to billing medical, like patience and persistence and being willing to make a call and get on hold. You know, all those things that you experience with dental insurance, they're present in medical insurance too. There's just a different set of documentation that's required. Probably one of the biggest problems with billing medical insurance is successfully doing it. And by that I mean, like you'll attend a lecture like the one you're attending right now, and then what will happen is you'll submit a claim and it will get denied. And you'll think, well, geez, I did everything that Jeff told me to do, and they denied my claim. Almost every first claim gets rejected the first time you submit it. And so one of the key attributes that you have to have if you decide to proceed with billing medical insurance is tenacity. You need to learn what the specifics are. So, for example, when you have a certain requirement and you submit a document that you believe satisfies a requirement, and it might, in another payer, this particular payer may not accept that document, and they'll just say rejected, and you'll have to find out why, and they'll say, well, that document that you used, and then you'll have to use a different document to satisfy that requirement. So you'll have to learn. It's almost in some components of billing medical insurance, it's kind of trial by fire, and there's just a certain amount of that. Hopefully it's minimized, and you can quickly learn the specifics for each payer in your area. And so as a result of all those, those three primary challenges, there is an upfront investment in your time and money. Okay, so there's some setting up, configuring, some your procedures in your office, and then you're going to submit a claim. And even when the claim is successfully submitted, you still have a period of time where you have to wait for the benefit. Okay, and they have, like, I believe it's 90 days to pay you or tell you why they're not paying you. So if you don't hear from them for any reason after 90 days, they're actually in violation of one of their guidelines. So just like dentists they decide to bill medical insurance, they have guidelines. Payers have guidelines too, and they have 90 days to say no or here's your money. Okay. All right. Before I move on, I'm going to be referring to a number of documents during various parts of the presentation. And in your dashboard or your configuration panel, there is an item there called handouts, and you'll see there's a little 5 next to the handouts. If you have the desire on the handouts, I'm going to point them out to you. There's kind of an overall document from the AADSM, the American Academy of Dental Sleep Medicine, which is not a very specific document, but will give you some guidance and kind of point you in the right direction. There's a more specific information on billing oral appliances and medical. There's some codes in there, and actually some codes just changed, but that's still good information with the updated code. There's a flyer on what DDME and WHIP sells, so that's Bruxism and Airway flyer. You see that, and I'd love you to take a look at that and see what we're all about with regards to the product and services that we offer the offices that work with us. The new codes that I referenced, the ICD-10, there is a map there of the old code to the new code, so if you're interested in that. And then finally, there's a letter of medical necessity. Okay. Okay, so let's talk about developing the strategy. So this part of the conversation is for the dentist who has not started billing or just started, and there's some reservations, and so maybe you want to reconsider the decision to bill medical insurance, or for the dentist that's new to this and they kind of want to get an idea what's involved so they can make an informed decision. So the idea of knowing what's involved, I've explained it a little bit, but we'll go into a little more detail, and then you can say, okay, if this much is involved, it's for my practice, this strategy makes sense. So there's in-house billing, meaning someone in your office has decided to volunteer, or you volunteered them to bill medical insurance. And so that individual in your practice will need to get kind of learn all the things we're going to talk about, and then execute those, and then learn the specifics of what your payer in your area require, and then develop the procedure to satisfy those requirements every single time. The beauty is on in-house billing, once you figure it out, it's cookie cutter, and therein lies where the opportunity is when you can develop the mill of getting this paperwork and documentation organized and done correctly on each and every patient. It does become very efficient. It helps your patient, and it becomes additive to the success of your practice. Okay, so if you're going to do in-house billing, someone's going to have to spend a fair amount of time dealing with satisfying all the requirements to bill medical insurance. So that's, the FTE, the full-time employee there. Might not be full-time, but if you're going to make this a focus of your practice and you're going to do 10 or 20 patients a month, it's a full-time person. Okay, so because it is a fair amount of work, just like it is with dentistry. It's probably actually a little bit more. I don't know a lot about dental billing, a little bit. I know more about the medical billing side of things, and I know that there's a lot of fussing on the specifics of successfully submitting a claim. The learning curve can be expensive for that person, meaning it can take a lot of time and energy on an individual to fight denied claims, figure out what went wrong, make the correction, and resubmit. That could be a frustrating period of time. I can't tell you how many times I've heard dentists say, geez, I've been at this 6 months and I'm still waiting to get my first check. other times the first one goes through, the first 4 go through, and then the trouble starts. So just know that there's a period of time where it's going to be a little bit, it's going to be learning, and the longer that learning takes, I equate that to expense. And again, I mentioned it a second ago, the idea of doing this successfully, that dedication and tenacity of that individual will pay off, especially if you decide to make this a major focus of your practice. It can be really gratifying, and what's better than providing a tremendous important service to your patients, and then adding, making it a successful component financially to your practice. That's just a great combination. However, I mean, there's some investment there. So perhaps maybe you want to outsource your billing. So if that looks like it makes more sense for your practice, know that on average, not every medical billing company that you call will accept dentists. Sometimes they're just really focused on a particular part in the medical field, and they've worked something out, and it's good. So that may take a few calls. You may know somebody. You may go to another seminar, and they'll recommend a billing service. I know I've recommended a few to people. DDME and WIPMIX, we do not provide billing services. We just have expertise in this area and can provide documentation, once you've worked out the process. If you're going to outsource, expect to pay between 7 and 10%. Some charge a little more, some charge a little less, but in general, if you're in that range of relinquishing that percent of the receivables to pay for the billing, it's well worth it. People that do this know that the first part, the in-house billing, there's some cost associated with that. Maybe they don't want to incur that. So that's the reason to outsource medical billing. Now, maybe there's a hybrid approach. And the hybrid approach, what I equate that to is the idea that you start one way and end another. So perhaps maybe you want to start right away successfully billing medical insurance, so you outsource it and just accept that to give up between 7 and 10% of the revenue, you'll have somebody else do it. But in the meantime, you're going to bring somebody up to speed in your practice. And then at some point when that individual gains the expertise where you're confident they could successfully bill the practice, then you flip a switch and you go in-house. So you start one way and end another way. And so you start with outsourcing medical and you end with in-house. Another hybrid approach would be to transition from fee to service to one of those two options. So you may start by not wanting to bill medical insurance at all. Maybe you'll start by saying that the charge for my services is X dollars, and let's make arrangements. And this is you talking to your patient. Let's make arrangements to set that for the financing of that fee, or this is the fee, and then you proceed down that road. That's the simple path, the easy path, but that path gets a lot of no's. Okay, so the fee for service, when you ask somebody for example, $3,000, and that I'll just use that as an example. If they don't see the value in $3,000, then it's going to be tough to get that out of them. And there's a number of ways in which we can describe how to talk about that, and we do that. We do that training, with our member dentists. But you all know, I don't need to tell anybody on this call that when you ask somebody for $3,000, you immediately introduce a risk to that service being provided. It's just, that's the nature of it. So, however, it is simple, and there are people that will pay it without question. So you may start with fee for service and then transition once you test it and see, is there enough patients in here? Should I give up 6 or 7% for medical billing service for outsourcing? Or should I do fee for service and train somebody how to bill medical and then flip the switch that way? So that's this kind of the second hybrid approach, going from fee to service to billing medical insurance. Okay. All right. I'm going to take a pause here real quick and just ask if anybody has any questions. All right. It looks like somebody said, I'm not hearing anything. Hopefully that's that person and not everyone. Okay, so it looks like, I have a little bar that says my microphone's working okay. All right, so let's do this. Let's go to the next slide. Let's talk about Medicare. And the Medicare option, you know, I've been doing this a few years now, working with dentists, and one of the first questions I get is, oh, can I bill Medicare? And then, you know, if that is the question to get started, it's not a good starting question. I'll say it that way, because to bill medical insurance, it absolutely is possible. However, there's some special considerations there. The first one, and the reason people ask the question, there's just a lot of Medicare patients. So, geez, if you could successfully bill Medicare, think of all those patients you could help. So that's kind of one of the attractions to being able to bill medical insurance. Past that, there's some extra work to be done for everybody. So what Medicare, first you have to decide that, yeah, you want to be a Medicare provider and go through getting your DME license number, your Medicare number, and you have to complete that successfully. That's one. Once you do that, then the additional work that's unique for Medicare compared to most private payers is that Medicare requires that the patient be seen face-to-face with the sleep specialist that interprets their study. Okay, so that does put a burden on some possible paths that we have as a dentist. So when you have a Medicare patient, it's almost the recommendation that I give to most people is receive a already diagnosed patient that's already been seen by a sleep specialist, and for one reason or another, CPAP was not an option, or the first option was an oral appliance therapy. So either of those two scenarios, just receive your patients diagnosed, okay? Because it's Medicare just wants it to be done that way. It's not a bad way. It's just it adds a burden to the process. Medicare pays on general about $1,300. So with $1,300, if you have experience with the work, that's probably not an impressive number compared to maybe what some of the other payers are offering, and also what what you could get for fee for service. The trade-off is if you can successfully gain access to that $1,300, there's a lot of patients that are in that category. So what you lose in reimbursement, you gain in volume. So if you can figure it out and be really efficient, that it is without question a great opportunity. Okay, so let's transition into private payers. And with private payers, there, you know, and I listed some of them up there, and so there's Blue Cross, Blue Shield, Aetna, Cigna, and there's others. And then there's HMOs, which is kind of a unique. They're not private. It's private, but it's a different business model, obviously from the private payers. Blue Cross, Blue Shield, Aetna, their job is to collect X dollar for medical benefit and pay out X minus dollars for it and keep the balance. Okay, so they're really interested in kind of their focus on the reimbursement and making sure that all the rules are followed. And if they collect a dollar, the less of that dollar they give away, the more successful the private payer is. Okay. The HMO model, which Kaiser is a big one. There's other HMOs, obviously, but HMO is the big one, especially on the West Coast. Their idea is they collect a fixed amount, and their model is what I just described. They want to collect X and then spend less than that to help the patient. So Kaiser is kind of, think of Kaiser as they're a private payer with their own hospital. They own the hospital. Think of it that way. So their motivation is to keep people healthy, and in doing so, most HMOs do put an emphasis on keeping people healthy, and one of the easiest ways to get somebody healthy is to manage their airway. So they are much more focused on airway and sleep labs than maybe some of the private payers who are kind of the middleman. Kaiser, there's really no middleman. Okay, so the deal with Blue Cross, Blue Shield, Aetna, Cigna, and so on. And I think there was a big merger there between Aetna and Cigna, but I'm not sure. But in any event, the idea there is you want to know that the patient has the benefit. So you're going to call and you're going to find out that if you're out of network, the out of network benefits is shrinking. So you do want to get in network. So just like as a patient wanting to get into get medical insurance, there's kind of an open enrollment month. Typically it's towards the end of the year. If you want to, the same with providers. It's no different. So with Blue Cross, Blue Shield, Aetna, Cigna, once a year they open it up, and if you want to be a provider, you can submit an application. Okay, and it used to be, and to some extent it still is, some benefit to being out of network, but that out of network benefits are shrinking dramatically. So you just have to be aware that if you're being successful at out of network billing now, that may not be the case, and you should be prepared to maybe shift gears a little bit and become in-network. And the first question they ask when you want to be an in-network provider is, what's your Medicare number? So that's why, on my previous slide I mentioned that there is some benefit. So let's talk about successfully billing private payer insurance. Okay. So the idea here is I'm going to take you step by step. In general terms, each step. Now, within each step, a payer might, I might say use an Epworth on step 6, and your payer might say, no, we want the stop bang. Or there might be some minor variation, but in general terms, what the steps we're going to talk about are pretty close to what you'll need to do. Okay, so step 1, initial intake. You have to have a reason to start. There has to be a suspicion of a problem, and that suspicion gets identified as part of your initial consultation, which is generally some questions. So a base initial consultation is typically you sit down with the patient, you talk to them after having the patient already filled out a questionnaire, you review the questionnaire, you identify the complaint or the problem, and as dentists we do a great job of that. And then once you've identified the problem and the complaint, that complaint needs to become part of the documentation that will eventually be submitted for the claim. On each case, when you submit a claim, that step, the first step in any claim is, what are we treating and why? Okay, if that's not obvious when you submit the claim to medical insurance, if they don't know that this is to treat sleep apnea, then you're in for a rejection. Okay, so document the complaint, initial consultation. So the patient said that they were tired, they scored a 15 on the Epworth, their neck is 17 inches, their BMI is 42. For these reasons, the patient is suspected to have obstructive sleep apnea, and that needs to be clearly documented. Okay, so that's step 2, documentation. Okay, so once you've identified that this patient is at a high likelihood to have sleep apnea, by the way, I'm going to insert my one of my first kind of comments here on bruxism is damaged teeth is a very good indicator for sleep apnea. Okay, so when I say the patient's tired during the day, scored 15 on the Epworth, what I should say on top of that, do they have damaged teeth? Okay, because people with damaged teeth have a very high likelihood to have sleep apnea. Okay, however, insurance companies don't look at it that way, but nonetheless, when you from the clinical perspective are evaluating your patient, you open up and you see damaged teeth, that should be okay. That's like an Epworth score of 20. Okay, as far as how likely it is that that patient's going to have a problem. Okay, so now that once you've identified the complaint, you documented the complaint and the reasons that support your complaint and test, you need to get a pre-authorization. Now, some payers require it and some don't. When you're new and you're trying to develop your process, call and find out, and if they say, sorry, no authorization needed, make a note in the chart. Or they'll say what's the group name and code, what's the patient, they'll get a bunch of information, and then they'll give you a pre-authorization for the test. Okay, this is assuming you've identified the patient. You haven't received the patient that's already diagnosed. I should have probably said that earlier. Okay, so now you either found out you don't need pre-authorization or you received your pre-authorization number, then you perform your test. Okay, obviously if your patient's already diagnosed, we're not going to do step 4 and 5. So you order your test, and DDME sells a monitor. It's a really good one. In my opinion, it's the best one. I've been doing these things, doing home sleep studies for many, many, many years. I designed home sleep study equipment, so I know a lot about them. There's good ones and there's bad ones. Not bad ones. There's ones that just that are more capable than others. But at the end of the day, you want one with certain requirements, and we'll talk about that in a bit. So you order your test and you get your results back, and that's going to tell you, am I dealing with a medical issue or not? And if there's anything on the AHI or anything in the results that indicate that there's a problem, that will be identified by the fact that a board-certified sleep physician needs to review your data. Now, if you have one across the street, or you know one, or with the case with DDME, we have a network of physicians that we offer their services to our dentists. So one way or the other, you have to get a physician involved. You cannot proceed without it. It's you know, when people say, oh, dentists can't be doing this or that, what they mean specifically is that dentists can't diagnose sleep apnea. It shouldn't mean that you can't own a screener, or you can't make an oral appliance, or you can't kind of be the quarterback in this process. It simply means dentists can't diagnose a medical condition. And to be honest with you, most dentists don't want to do that. They just want to treat their patient. So that's in my experience, it hasn't been a big issue. So then the physician says, oh, you're right. Your patient does have sleep apnea. Here's the diagnostic code. That recently changed. It was 328.56 or 27 or something. It's now a G code, and I'll show you those in a second. But so you have your diagnostic code. So you have a reason for the test, a suspicion of sleep apnea. You had a physician say they do have sleep apnea, and that physician also says, I recommend the following treatment options. Okay, and you get a document that says all this. The document should have an interpretation with diagnostic code and some treatment recommendations. You sit down with your patient and you decide, okay, here's our options, which one, and you work out, you explain the pros and cons of each, and that conversation is a great conversation for another topic, but not today. But in the case where, based on the results, the recommendations, and your patient needs, you've decided as the primary clinician on this that you're going to fabricate an oral appliance. The next step that I recommend, and it's not necessarily required, it's just a good idea, is get the patient's physician involved. So send them the interpretation from the physician in an unsigned prescription for an oral appliance. And there's a bunch of good reasons why that's a good idea. One is a lot of payers require it, but another reason is it gets your physician involved with a benefit you're providing that they should be involved in, because the physician should absolutely know that their patient's being treated for sleep apnea without question. So, and then it also creates a marketing opportunity. So, a lot of primary care physicians are very busy and they don't have a focus on sleep apnea. So if they learn that you do, that's a marketing opportunity, especially if they see what a good job you're doing from time to time, when you send them a prescription request. All right, so once you have that, then get a pre-authorization for treatment. Okay, so we're now working on our second pre-authorization. And then once you get that, or you learn that there's no pre-authorization necessary, take your impression, and the rest is dental. There's one more step on billing medical insurance, but you take an impression and you treat your patient. Now, the step in which, and one of the things that's really important is to understand what data service is. And in the medical field, they just want a data service. Now, from a clinical perspective, the data service for oral appliance therapy occurs over a long period of time. And so what you want to do is just make sure that the date that you fit your patient with an oral appliance is the day that is considered by most payers the data service. Okay, so I'm gonna go back one step. There's a question here, and it's a great question. It says, can a dentist pre-authorize an HST at the out-of-network level? And the best answer I would have for that is it's yes. It's definitely possible. I would say that the out-of-network, again, it's shrinking. And a lot of times, if you had asked me a year or two ago, I would have said yes without any hesitation. And today I would say yes, it's possible, but that window is shrinking. So hopefully, I think that was Melinda that asked that question. Hopefully that answers that question for you. Because it is, one of the denials. I'll tell you my experience here working through denials is sometimes a pair when you're new, they'll key on the focus that you're a dentist, and they'll see a dentist and say, oh, you're not a qualified provider. Okay, so then you'll have to provide some documentation to fight that claim. List the CEs that you have, any certificates that are documentation that you've been trained in this area, and maybe a procedure that you follow in your office. And then you say, for these reasons, I believe that I am a provider, and you work through it. Once you work through it once, they'll say, oh, okay, and then the next time they see a claim, they see a dentist, they'll say, oh, yeah, but this is, and it'll go through, okay? So it is, and there's, we had some success asking for gap exception. Absolutely. There's a number of strategies here, and you may learn. They may say, sorry, your claim is denied, and they may guide you to the gap. They may say, listen, it might be better to try the gap, and the gap is kind of an area in a patient's benefit that falls outside the clearly listed component to their benefit. And there are some dollars that's available in that area, okay? All right, so getting back to this, you fit the patient for the oral appliance. So you took an impression, you sent it to the lab, you received the impression back, you made an appointment and you fit it, you maybe heated it in water or whatever, you got the patient fitted, you started in some comfortable protrusive percentage point, and you let the patient get used to it. So when you do that initial fitting, that's data service on your 1500 form. For you billers, for you people non-billers, just know that the data service for most payers is when you fit. Now, we all know that there's a process that happens after that, but the way the medical insurance is, they want a date, okay? And you don't have to be done, and it isn't contingent on successful treatment. Successful treatment's not as clearly defined in oral appliance therapy as it is CPAP or positive pressure therapy, but as long as you've done your initial consult and you're in the titration process, my recommendation is submit the claim, because when you submit the claim, then there's another period where there's a wait. So that's the process in a nutshell. I'm going to go through quickly. These are some of the forums that are available to you on the download, on the handout section, excuse me. And I did want to mention that if this webinar is of benefit and you want to learn more, part of what DDME offers is ongoing education. So what we would do if you're not already a customer of DDME and WhipMix is we'll do a one-on-one webinar, and we'll go through, we'll determine, does it make any sense for you to join our network and get a monitor and test patients yourselves or not? And then from that webinar, we'll go through the decision process, and then based on what makes sense for you, we can go down the path of working with you in greater detail, okay? So, but for the billing part, again, I talked about getting documentation. Here's kind of the basics, which I'm sure you all do. This one might be a little new, where you have to document the sleep complaint. Observed pauses in breathing, snoring, excessive daytime sleepiness are examples of documenting the complaint, okay? You cannot say, I think the patient has apnea, okay? It needs to be the patient's tired during the day, their BMI is above 36, there needs to be a kind of data points that are accepted by your payer, not just that you as a very trained dentist thinks that they have apnea. As obvious as it might be to you, when a payer is reviewing the file, they just are looking for certain things, and they want questions answered a certain way, okay? So document the complaint. Let me see my time. Okay, I'm doing okay on time. One of the more popular question points for payers is the Epworth, which is an assessment of how tired a person is during the day and their ability to stay awake during the day during normal kind of daytime activities. And a lot of payers like to see this. And so, in fact, some of them require it, some of them don't. And it just depends on the path of that your payer has. I can tell you, when you're dealing with a sleep disorder, one of the challenges is the patient's asleep, and the toll that the sleep disorder takes is over a long period of time. It's kind of like smoking. One cigarette isn't going to give you cancer, but over a long period of time, there's a number of issues that take its toll on a smoking patient. And the same way is sleep apnea. And the reason I bring that up is patients may not even perceive that they've been impacted by it. So, for example, one of the things I always find almost humorous is with hygienists. And I'll talk to a hygienist or a group of hygienists, and I'll say, do you ever have a patient fall asleep in your chair waiting for you to clean their teeth? And all the time. My patients really love me and they're relaxed, and so when they're waiting for me, they just fall asleep because that they're just relaxed. And actually, in reality, a sleeping patient in a dental chair is a great sign that the patient has an airway problem. Okay, and what's really funny is you might have to wake them up to give them this questionnaire, and they'll get all zeros. Say, I'm not tired during the day, and you had to wake them up to give them the sleepiness questionnaire. So that's, just know that patients a lot of times won't be aware of their problem. Now, with the Epworth, I would say these numbers are used to evaluate whether or not your medical benefit can be used for your treatment. Because a lot of times people want to deny it. And the Epworth questionnaire, its primary role is to see are you qualified to receive benefit? And if you score all zeros, you have to be strong in other areas in order for it to get the appliance to get paid for. So just know that your patient should understand that. Let's see, can you go back? So, somebody who was this, looks like Marty. Marty, I'm going to actually make available the presentation I'm giving today. So it looks like you maybe you're taking screenshots or something. I think maybe you wanted to go back one slide. I'll just shoot me an email, and actually I'll give you my email address at the end, and I'll give you this whole slide deck, and you won't have to be bothered with that if you want. Okay, so and moving on with documentation, just like there's the Epworth, there's the stop bang, which is, do you snore, are you tired, what have you, and based on the end of the stop bang, you make a decision that the patient is likely to have some type of sleep apnea problem. There's the Mallampati, great assessment tool. Insurance payers don't necessarily recognize that, but from a clinical perspective, it's a great tool. So you can kind of see there on the Mallampati, there's 4 classes there, and based on what class your patient falls into, for you as a clinician, it gives you good information on the likelihood that soft tissue is just going back into the airway. So the higher the class, the more likely that tissue is that's sitting on the mandible is going to kind of end up in the back of the airway. Okay. All right. So then you've done your test. You did your initial consult. You've done a test, and then the physician needs to provide you a read. Okay. So this is an example of a read. Now, in this particular case, I have an old code on here, 327.53. That CPT code has been updated to G something, and I have it here in another slide. I just noticed that I didn't update that code there. You have to have a code. You have to have a set of treatment recommendations from a physician. If you don't have those two, it's a very short trip to the insurance payer. Don't even bother. And it's important to understand the difference between an interpretation and a report if you're new. Forgive me if you're not new, it's obvious, but sometimes people are new, they'll see the home sleep testing software comes up with these really great reports, and they're impressive looking with charts and so on and so forth. But payers generally don't want to see that. Payers want to see the letter from the physician. saying you have sleep apnea and what I think and what the physician thinks the patient should do to treat their sleep apnea. That's what payers want. Okay, so there's an example of that. Now, if you receive a referral from a sleep lab, this needs to come with the patient. You have to have, if you don't make arrangements for a physician to interpret your studies and you're receiving patients already diagnosed, you can't just accept that the patient says they were diagnosed or even the sleep lab called and says they were diagnosed. You need the interpretation from the sleep lab to get started. Okay, so when you accept the referral, you probably have some type of referral form for the sleep lab. And then the sleep lab, on that referral form, it says you are required to send us a copy of the patient's diagnosis. Okay, so you have your referral and some type of report that has this basic information. Alternatively, if you've ordered the test yourself and the physician needs to provide you back this same type of information. But one way or the other, a physician needs to get you a report. You know, and there's a lot of debate on which path is better, but you just need to decide for yourself on what path is better. Now, if you're going to take a patient that has seen a physician, and one of the things that payers like to see is a signed letter of medical necessity. So I did mention before that if you're going to, I recommend that you get involved, the patient's primary care physician or general physician. There's actually 3 documents that I like to see. The interpretation from the sleep specialist, the unsigned prescription saying oral appliance therapy used nightly to treat sleep apnea. The 3rd document is a kind of a canned letter of medical necessity. Okay, so with those 3 documents, the payer process will go much better. Now, alternatively, if you have a failed CPAP patient, instead of a letter of medical necessity, you have to have a letter of non-compliance. So either or, but you either have a letter of medical necessity or a letter of non-compliance. Both those need to be signed by a physician, the patient's physician. The letter of non-compliance, I like to have the physician that prescribed CPAP initially, that physician should sign the letter of non-compliance. And the letter of non-compliance will say something to the effect, my patient made an honest effort to be compliant with CPAP, and for these reasons, they were not able to tolerate the therapy. As a result, I recommend an oral appliance to treat this patient's sleep apnea. That needs to be the content of the non-compliance letter. I have samples of them. And if you want that, again, you know, I have a 12 more minutes, so I need to be moving along. But at the end, I'll give you all my contact information, and we can schedule one-on-one sessions, and we can go through some of this stuff in a little more detail. Here's a sample of a prescription. There's the new code there, G47.33. That's the new ICD-10 code. The therapy number, I believe, stays the same as E0486. And then trial of a custom oral appliance to manage OSA and use nightly. That's a standard prescription. Okay, so what I want to do now is I want to spend just a few minutes talking about testing your patients, taking measurements of your patients of their airway and Bruxism. Even when you receive a referral from a sleep lab, the patient's already diagnosed with a prescription for oral appliance therapy. Once you get started, you really do need to measure your patient on the progress of the titration, okay? Because titration occurs over a period of time, and you need to know, okay, I started at 50% protrusive and I ended at 85% protrusive. Am I better? Is my patient better? You know, if their AHI from the sleep lab is, you know, 20, and you go 85% protrusive and the AHI is 6, that's great. But the only way you're going to know it's 6 is if you do a measurement. So even in the case where you're lucky enough to say, I don't need to test any of my patients, I have a steady stream from a sleep lab, you know, first of all, congratulations, that's great, and we all will work towards that. Second, again, it still makes sense to monitor them, because to send them back to the sleep lab to do a kind of a compliance test becomes then very expensive, but you know, a lot of times that's what's necessary. So in lieu of that, do your own testing. So the monitor that we use at Whitmix and DDME is called the Bruxism monitor. It's the T3 from Iceland, and it's a great unit for measuring the airway and bruxism. And a lot of people say, well, why bruxism? Well, bruxism, one, is a dental issue. So anybody that has any doubts as to whether or not a dentist should be doing a test, if you add bruxism to a test, how could you even deny that that's a dental test? Okay, so that's one reason. Moreover, what impact does the airway have on a patient? So it could be that the patient has damaged teeth and they have an airway issue, but it's not sleep apnea. Okay, that's another reason to do a test and do bruxism, because they have damaged teeth, but they're not full-blown apneics. Okay. Third is the data from the monitor is of sufficient quality and technical content, or clinical content rather, that any physician would be very comfortable diagnosing a patient after reviewing the data and knowing a little bit of information about the patient. So for these three reasons, it's a good idea to test your patients. Okay, so in the monitor we use, here's the basic test, our basic steps for the test. It's a very simple thing. There's a download in the morning, and in the morning you get some basic numbers, and then you decide, oh geez, my patient does have apnea, I better get a physician involved, or not. And then you also know how much bruxing, clenching, and grinding, and so on and so forth is going on. From a dentist, that's really important if you're going to make them an oral appliance. Here's a report. I use this as a triage report. It gives you an AHI, it gives you an ODI, it gives you the percent snoring, and then the decibels of the snoring. And then it also gives you total number of clenching, how strong those clenches are, grinding, how many times they grind, the overall EMG activity that's kind of in another bucket, because as dentists, we kind of know that clenching and grinding is what causes damage to teeth. But there's a lot of other EMG activity that occurs at night. We're able to detect that and put it in another bucket so it doesn't cloud up the bruxism numbers so much. Okay, so you'll know with our report exactly how much clenching and grinding is going on, what their AHI is, and so on and so forth. So what happens as a result of testing your own patients, you know, I'm going to shift gears a little bit, is when you're treating a patient, if you start immediately treating them, that's when they're willing. If you've tested your patient and you wait for 3 weeks to get the appliance back, the willingness kind of can wane in that 3 weeks. So I always like, you know, to improve compliance, do everything you can. One of the best things you can do with compliance is getting something in their mouth early. So once you've decided to make an oral appliance, we have there's an appliance called the BRX Pro, and it's a dual arch occlusal guard, and it's meant to support the mandible and protect the teeth while you're making your final decision, which could take literally weeks or even a month or more. And in that period of time, you got something going in their mouth. You get them acclimated to oral appliance therapy. It's inexpensive. It's made in like a few minutes, and it gets patients started. I know this from the sleep lab. If you wait a month or 6 weeks, and then you call somebody back and say, oh, I want to put you on CPAP. They said, oh, I'm okay. I'm better now. I don't snore anymore. Okay, and that happens a lot, even in the sleep labs. So you just be aware that we like that for compliance reasons. There's a great option to get somebody in something quick. It's the BRX Pro. There's some information on here, and again, it's made chairside. It's a pair of trays that have 4 positions, and it's basically a hold forward occlusal guard. So if you've ever manufactured one of those, but it's already pre-manufactured, and you just pick your position based on the patient's natural bite. We've done quite a bit of testing with it, and it works very, very well for a short period of time until you transition your patient into a long-term therapeutic option. Okay, it works great for snoring, and so what I wanted to do after we finished talking about the BRX Pro and the importance of getting something in the patient, treating them right away, is I kind of wanted to wrap up, and then I wanted to see, based on the conversation that we're having, I talked quite a bit about medical insurance, the pros, the cons, develop a strategy on, if you're not already doing this, okay, and I do want to do this, what's the strategy to achieve the goal of billing medical insurance? And now that you have more, information on kind of the requirements, testing requirements, who's the team is the dentist, yourself. It's going to be a sleep specialist to review the data. It's going to be a sleep lab and the patient's primary care physician. Okay, so that's the team. You have to have a team. That's one of the things that some dentists find challenging is other people need to be involved in the process. So I wanted to make sure that you all understand that. And then, do you have any questions? Okay, there's a question coming in. So by all means, start typing the questions, and I'll bring them. I'll answer them. Scott asked, how would we find a link for the recording? So I have kind of an attendance list. I think the best way is you see my email address there. Because I don't automatically, I'll automatically send you an email kind of thanking you for attending, and then there's going to be a link to the recording. So if you missed part of this, or you want to kind of review it, or you want to send it to a friend or whatever, you will be getting a kind of a thank you email and inviting you to ask any more questions that maybe come up later. And in that email will be a link to the recording. Okay. So is there, so I'll just kind of give you guys a second to see if there's any other questions that are coming up. Let me look here. Let's see there. Okay. All right. Doesn't look like there's any questions there. Okay, so it looks like we're pretty much done. I'm going to keep the meeting going for a few more minutes. But I'm going to go ahead and just let the meeting run. And then if you have any questions, let me see here. It looks like another question just came in. What is the investment for the home monitor? So there's a couple of options there. It's $4,400 for the monitor, and then there's training and supplies and services that are available based on what you want to do. We have a rental option, which is $429 a month. And 25% of the rental fee can be applied towards a purchase. The benefit of the rental is after 3 months, if you want to send the unit back and say, listen, this just isn't working, you have that option. And the other benefit to the rental is that, 5 or 4 months or more, and you say, this is working great, I really like this, I'd like to purchase it, 25% of that fee can go towards the discount of the acquisition of a monitor. There's a leasing option. There's 2 leasing options, one for $275 a month and the other is $329 a month. And at the end of the 2-year lease option, you own the unit. And then you can purchase the unit outright. So those are the the total cost just depends on what you sign up for. But yeah, generally it's about $20 in supplies to do a test. That includes the surface EMG for the masseter, a cannula for the airflow, and the 2 belts to measure respiratory effort. Okay. Let's see here. Do you know if you sign up for Medicare as DME provider, do you have to provide other services to Medicare patients such as, no. The idea, when you get your Medicare number, you're going to tell them what services you are willing to provide. And there's rules about turning people down, but the services that you provide are that's one of the application says, okay, are you going to be providing CPAP, oxygen, wheelchairs, and then they'll want a list, and you just provide E0486, which is oral appliance therapy customized to treat sleep apnea, and then that will be the expectation. If you tell them you're going to treat other things, then yes, you are obligated. All right, so there's another question here. I'm just, let me get to that. Okay, great. How is the billing for reading of the home monitoring through DDMA test handled? Okay, Scott, the way that's handled is the data gets, when you download the data, and I kind of showed you that download screen, I showed it real quick, but then a decision's made, do I want a physician to diagnose this patient, or maybe I just want to refer them straight to the sleep lab without making arrangements for a physician. If you decide to make an arrangement for a physician to provide the read, a copy of the data automatically goes to our server. So the data gets downloaded to your hard drive on your computer, and nobody does anything unless you send an email saying, please provide a read for this particular patient. Then that fee is $109 for the physician. In the case where you do a download and you do not need a physician, maybe it's just a follow-up study, or maybe you want to see where the patient is on the titration, and there's no charge for those tests. Okay. Okay, let's see here. I'm going to scroll. Looks like I might have missed a question here. We send it to a specialist online. How do we have them meet with the okay, so the question, and this is a very good question, and this comes up fairly frequently with Medicare. So the question is alluding to the sleep specialist having a face-to-face meeting with the patient. And in the case where DDME, where the study is ordered through DDME, we do not provide that. So if you believe that's required, or you have a Medicare patient where it is required, that path is not an option for you. So in the case where it's a Medicare patient and everything looks positive, then you would just need to refer that patient to a local sleep lab. And that sleep lab will sit down with the Medicare patient, provide an interview or an initial consult, just like the same one that we talked about you providing, and based on the physician's initial consultation, perform face-to-face on the Medicare patient, a form gets filled out, and Medicare does require that. And also some dentists feel that's the best way, and it is a great way to do it for all patients. But one of the consequences I didn't mention with regards to doing the making arrangements for the diagnosis yourself or referring the patient to a sleep lab, the cost is a home sleep study. On average, our dentists charge about $200, $250. And that can go towards their deductible, or that could be fee for service. Sleep lab is probably a $2,000 event. So if the only thing that you suspect is sleep apnea, then some dentists that I talk to, they're very cavalier, and they've achieved the level of success where they just say, oh, I just refer my patients to the sleep lab and I don't have to worry about it. That's a great outcome. However, you're also saying, I'm going to have my patient pay somebody $2,000 instead of me doing it for $200. And based on your philosophy and approach, that's the financial dynamic of saying sleep lab should do it versus perhaps you getting into ordering the test. Okay. Going through here with the questions. Okay, so that was a question on getting the presentation. And again, the presentation, there'll be a recording of the presentation made available through the email, thank you email that we'll be sending. If you want the slide deck, somebody was talking about the picture or what have you, you'll email me directly and say, I went to your webinar on insurance and I'd like the slide deck, because the link that you're going to get in the thank you email is a video, and you can't really kind of capture the picture if you wanted to capture it for some reason. So just to let you know about that. All right, so let me make sure there's no other questions. Thank you for getting involved. I appreciate questions. As a presenter, one of the outcomes you want to avoid is the crickets at the end of the presentation. So I do appreciate these questions. Let me see here. Okay, we did the investment, and I'll tell you, if you're close to making a decision, and we just have to work out some numbers, we'll make it work for you. We'll find a way. If you want to get started. All right. Okay, it looks like that I got that question. Okay, so I'm going to go ahead and end the meeting. Again, thank you for joining me on a Friday, and appreciate everybody's time today. Have a great weekend. Thanks.